Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today, we are walking into what is, I think, arguably the most intimidating room in the pediatric hospital.
Oh, absolutely.
We're tackling the beast. And when I say beast, I mean the one unit that seems to strike absolute fear into the hearts of nursing students, new grads, and, even seasoned nurses more than any other system in the body.
We are talking about the heart.
We are talking about the heart. Specifically, Chapter 19, the child with an alteration in cardiovascular status. Now, I've got to be honest with you. When I first looked at this stack of slides, the textbooks, the ATI notes, all the stuff you sent over, I felt my own blood pressure go up.
I believe it.
You've got defects with names that sound like, complex spells from Harry Potter to Trilogy of Fetal, transposition of the great arteries. You've got hemodynamics. You've got physics. You've got medications with therapeutic windows so narrow they're practically invisible.
It is intimidating. I think for a lot of learners, the cardiovascular system, it just feels like a maze. You turn one corner and you're dealing with electrical conduction, you turn another and it's plumbing and pressure gradients.
Right.
And unlike, say, the skin or the bones, you can't see what's happening. It's all hidden inside the chest. So if you don't have a map, you get lost very, very quickly.
And in pediatrics, getting lost can have, catastrophic consequences. Things happen fast.
Oh, fast.
Exactly. And the stakes. They couldn't be higher. We're talking about the engine of the body, keeping the blood moving, keeping the brain oxygenated. So here is our mission for today's deep dive. We are not just going to read the textbook to you.
Yeah.
We are going to adopt a persona.
Today we are the pediatric nursing exam coach.
I like that. The exam coach.
Yeah.
Yes. Right. We are going to cross-reference all these sources, and we are going to find the Pareto principle, the 80-20 rule. We want to identify the 20% of the material that is going to answer 80% of the exam questions and, more importantly, the 20% of the concepts that are actually going to save a life at the bedside.
So that's the only way to do it.
Because you can't memorize everything. If you try to memorize every single anatomical variation, you'll drown.
You will. That is the perfect way to approach this, because if you try to memorize every single anatomical variation of every single defect, you will burn out before you even get to the acquired heart diseases. You need a framework. You need a map.
A map.
Yeah. If you understand the why, the what becomes obvious.
So lay out the roadmap for us. How do we conquer this beast?
Okay, so we're going to break this down into 4 main kill zones or, priority areas.
Yeah.
First, we're going to build the master map. This is the physics. If you understand pressure gradients and the transition from fetal to newborn circulation, that critical switch, you don't need to memorize half the defects. You'll be able to predict the symptoms just by logic.
I love that. Physics over memorization.
Exactly. Second, we're going to tackle the defects themselves, but we aren't going alphabetically. That's a huge mistake.
Okay.
We are going to categorize them by blood flow. Is the lungs getting too much blood? Too little? Is the plumbing kinked? That organizes the chaos.
I like that. Grouping them.
Third, we have the acquired conditions, things that happen after birth, like Kawasaki disease and rheumatic fever. And finally, we have the nursing safety kill zones. These are the medications like digoxin and procedures like cardiac cath, where if you don't know your stuff, you can do serious harm.
And throughout all of this, because this is pediatrics, we have to keep one question in the back of our minds, right?
Always.
How does this heart problem stop a child from being a child?
Precisely. A heart defect in a 40-year-old is a medical problem. A heart defect in a 4-month-old, that's a developmental crisis. It affects feeding, growth, everything. We have to look at the patient, not just the pump.
Okay, let's unpack this. Part 1.
Yeah.
The master 80-20 map. You mentioned pressure gradients. I feel like I need a refresher on high school physics here. Why is this the absolute need-to-know concept?
Because blood is lazy. That's the golden rule you have to write down.
Blood is lazy. Okay.
If you write nothing else down today, write this. Blood will always flow from an area of high pressure to an area of low pressure. It follows the path of least resistance. It doesn't want to work hard. It's like water flowing downhill.
Yeah.
Simple as that.
Okay, blood is lazy. I can relate to that.
So let's look at a normal, healthy adult or child after they're born. The heart has two sides. The left side is the powerhouse. The left ventricle has to pump blood all the way to your toes, your brain, your fingertips against gravity. Has to overcome the resistance of the whole body, the systemic vascular resistance.
So it's working hard.
It's working very hard. So the left side is high pressure.
Left is high. Got it.
Yeah.
That's the heavy lifter.
The right side, well, it has a much easier job. It only has to pump blood next door to the lungs. The lungs are spongy, they're low resistance organs. So the right side is low pressure.
So left is high, right is low. That's our baseline. That's normal.
Correct. Now imagine someone punches a hole in the wall between the left and right side, a septal defect. Which way does the blood go?
Well, if the left is high pressure and the right is low,
Huh.
and blood is lazy, the blood is going to get pushed from the left to the right.
Boom! You just solved 50% of the exam questions. I'm not kidding. If there is a simple hole, like a ventricular septal defect, a VSD, or an atrial septal defect, an ASD blood flows left to right.
Okay, and what does that mean for the body?
It means oxygenated blood that should be going to the body is leaking back into the right side and going to the lungs again.
It's doing an extra lap.
An unnecessary and damaging extra lap. The lungs get flooded, they're overworked, and the body, well, it gets less blood than it should.
But the blood going to the body is still pink, right? It's oxygenated.
Exactly. That's the key distinction. In a left to right shunt, the blood that makes it out to the body has plenty of oxygen. The kid is pink. They aren't blue.
Okay.
But their lungs are wet. We call this pink but wet, or acyanotic but with signs of congestive heart failure.
Pink but wet. That's a great visual. Now flip the script for me. What if something blocks the lungs?
Okay, good question. Let's say the path to the lungs is tight. We call that pulmonary stenosis. The door to the lungs is narrowed, so the pressure on the right side starts to build up because the blood can't get out.
It's a traffic jam.
It's a traffic jam. It's pushing against a closed door. Eventually, the right side pressure gets higher than the left. Now, which way does the blood go through that hole?
It would have to reverse. It would go right to left.
Yeah, what kind of blood is on the right side?
Deoxygenated blue blood.
And now you're pumping that blue blood across the hole and out to the body. That child is cyanotic. That child is blue. That's the fundamental trick. Left to right is wet, right to left is blue.
That simplifies it so much. I don't have to just memorize a list of symptoms for every single defect if I can just stop and ask, where is the pressure higher?
That's the master map. Now, before we apply this to the specific defects, we have to talk about the switch, because babies don't just pop out with adult circulation. This is where fetal circulation trips everybody up.
Right. In the womb, the fetus is basically underwater. They aren't breathing air.
Exactly. The lungs are filled with fluid. They are clamped down, high pressure. They are closed for business. Mom is doing all the breathing work via the placenta.
So the body needs a workaround.
It has these special shortcut shunts to bypass the lungs, because why send blood to the lungs if they aren't doing anything?
And these are the famous Latin names: foramen, ovale, and ductus arteriosus.
Think of them as escape hatches. The foramen ovale is a little flap, a hole between the atria. It lets blood skip the right ventricle and go straight to the left side. And the ductus arteriosus is a little vessel connecting the pulmonary artery directly to the aorta. It's like a highway bypass. It says, hey, don't go to the lungs, it's a dead end. Just go straight to the body.
So in utero, bypassing the lungs is good. It's necessary. The right side pressure is high because the lungs are clamped shut, so blood flows right to left through these shunts.
Correct. But then the baby is born, the cord is cut, the baby takes that first big breath. Wow, what happens in that moment?
I assume the lungs open up, like really open up.
That first breath is magic. It's an incredible physiological event. The lungs expand with air. The resistance in the pulmonary vessels drops like a rock. Suddenly, the right side becomes the low pressure side.
And the left side?
Well, at the same time, the cord is clamped, so the systemic resistance goes way up. The left side becomes high pressure. This dramatic pressure shift slams those doors shut. The foramen ovale closes. The ductus arteriosus starts to constrict and close over the next few hours or days.
It's like a complete plumbing renovation that happens in seconds. The walls go up, the doors lock.
Ideally, but this is the exam writer favorite section. You need to know 2 medications regarding these shunts, because sometimes the door stays open when we want it closed, or sometimes, and this is critical, we need to force it open to save a life.
Okay, hit me. Let's start with closing the door. When do we need to do that?
Let's say the ductus arteriosus stays open when it shouldn't. We call that a PDA, a patent ductus arteriosus. It's now acting like a left-to-right shunt flooding the lungs.
Because the pressure has switched. Left is now high.
Exactly. So we want to close it. We give a drug called indomethacin.
Indomethacin, that's an NSAID, right? Like a super strong ibuprofen.
It is. It works by blocking prostaglandins. Prostaglandins are the chemical that keeps the ductus open in the room. So if we block them with indomethacin, the door closes.
Indomethacin closes the door. Got it.
But, and here's where it gets really interesting and really high stakes. Sometimes a baby is born with a horrible defect where the plumbing is totally messed up. Maybe the aorta is connected to the wrong side. The only way that baby survives is if some blood can mix through that fetal shunt.
So if the ductus closes?
The baby dies, because there is no other way for oxygen to get to the body.
So in that case, we want to reverse nature. We want to keep that fetal door propped open.
Exactly. We need to keep the fetal shunts open until the surgeon can get there. For that, we give prostaglandins, specifically a drug called alprazolam. Prostaglandins keep the ductus open.
Okay, so I need a mnemonic for this. Indomethacin sounds like in comes the door, closing it. And prostaglandins, well, P for prostaglandin, P for prop it open.
I usually say prostaglandins provide a path, but prop it open is great, whatever works. Just remember, NSAIDs like indomethacin close, prostaglandins open. If you mix those up on a test or in real life, you've killed the patient. It's that serious.
All right, we have the physics, we have the fetal switch. Now, let's walk into the patient's room. Part 2. Assessment red flags. You're looking at a 6-week-old baby. What is the #1 absolute can't-miss sign of cardiac disease?
Sweating during feeds.
Sweating, not chest pain, not clutching the arm.
Infants don't clutch their chest, and they don't run on treadmills. Their stress test is eating.
That's a great way to put it.
Feeding takes a huge amount of energy for a baby. They have to suck, swallow, breathe, coordinate all of that. If a baby has heart failure, their heart just can't keep up with that demand. So the sympathetic nervous system kicks in fight or flight. They start sweating, usually on the scalp and forehead, while they nurse or take a bottle.
That is such a vivid image. We have a case study in the source material, Logan, 6 weeks old. His parent says he falls asleep while feeding, but he never finishes the bottle, and his little head is always wet with sweat.
That is a classic textbook clinical one-liner. Diaphoresis plus fatigue during feeding equals early heart failure. If you see that on an exam or in triage, alarm bells, flashing red lights, everything should be going off in your head.
And why is that so bad?
Because that child is not gaining weight. They're burning all their calories just trying to breathe and circulate blood. We call it failure to thrive, but really it's the heart failing to support growth.
So developmentally, this child is just completely stalling out.
Exactly. The calories are going to survival, not to growing the brain or the bones or hitting milestones.
What about vital signs? I know kids aren't just small adults. The numbers are totally different.
They are drastically different, and you have to know the ranges. The younger the child, the faster the heart rate and the lower the blood pressure. A newborn might have a heart rate of 140 or 150, even 160. That's perfectly normal.
And if you saw 150 in an adult?
You're grabbing the crash cart.
Yeah.
But in a newborn, you document it as normal. An adolescent, on the other hand, might have a heart rate of 70, just like an adult.
And blood pressure.
This is the trap. In an infant, a normal BP is something like 80/55. If you see 80/55 in an adult, they are hypotensive and you're worried. In a baby, you're happy. You have to know the age-specific norms. They're not intuitive.
And the source material mentions a specific trap about when to assess these vitals.
Yes, this is huge. If a baby is crying, screaming, or fighting you, their heart rate and BP will be sky high. You cannot interpret that data. It's useless. A crying baby might have a heart rate of 200 just from rage. It doesn't mean they have SVT. It means they're mad. You have to measure vitals when the infant is calm or, ideally, sleeping.
Quite exam.
It is a skill. You have to learn to be a ninja. You enter the room, you listen to the heart and lungs before you stick the thermometer in or put the cold cuff on. Do the least invasive things first. Once they cry, your good data is gone.
One last assessment piece before we move on. Clubbing and polycythemia. These sound like old-timey pirate terms.
They kind of do, and they go together. If a child has a defect where they are chronically hypoxic, low oxygen for months or years, the body tries to compensate. Two things happen.
Right.
One, the tips of the fingers and toes get wide and round. The nail bed gets spongy. That's clubbing. It's a sign of chronic, long-term oxygen deprivation. You will not see this in a newborn. It takes time to develop.
Okay, so clubbing tells me this has been going on for a while. It's a history lesson on their fingertips. What
Yeah.
about polycythemia?
Poly means many. Cythemia means cells in the blood. The kidneys sense low oxygen and they scream at the bone marrow, "Send more red blood cells! We need more oxygen carriers!" So the body produces a ton of RBCs. That's polycythemia.
More red blood cells sounds good, though, right? More oxygen carriers.
It's a double-edged sword. It's a good intention with a bad outcome. Yes, you have more carriers, but your blood becomes thick, like a milkshake instead of water.
Oh, I see.
And thick blood moves slowly. It can clot. So these kids are at a huge risk for strokes. That's why hydration is so critical for them, to keep that thick blood moving. If a polycythemic kid gets dehydrated from, say, vomiting or diarrhea, their blood can turn to sludge. It's a medical emergency.
Fascinating.
Okay.
Okay, let's move to the meat of the episode, part 3, the defects. We're going to use your method grouping them by hemodynamics, by blood flow. Let's start with group A, increased pulmonary blood flow, the wet lungs group.
Right. Remember our map. This is a left-to-right shunt. Blood is leaking from the high-pressure left side back to the low-pressure right side and going to the lungs again. The lungs are overcirculated, they're boggy, they're wet.
The usual suspects here are ASD, VSD, and PDA. So let's break down the VSD first. The source says this is the most common congenital anomaly.
It is. Ventricular septal defect. A hole between the ventricles. Because the left ventricle is the big pumper, it pushes blood forcefully through that hole into the right ventricle. This creates a lot of turbulence.
Which you can hear.
So on the exam, you are listening for a loud, harsh murmur at the left sternal border.
Loud and harsh. Left sternal border. And what happens to the kid? How do they present?
They usually aren't blue, so they're acyanotic because plenty of oxygenated blood is still getting to the body. But they are tired. They have pulmonary congestion. You'll hear crackles, wet lungs. They get respiratory infections constantly.
Why the constant infections?
Wet lungs are a petri dish for bacteria. Fluid stasis just breeds infection. So developmentally, this kid is the one who's always missing school or daycare because they have pneumonia. Again.
And they're probably not growing well.
They're falling off the growth chart because they're too tired to eat and they're burning all their calories just trying to breathe against those wet lungs.
The good news is many of these close on their own.
That's right. Spontaneous closure happens in about half of small VSDs by age 2. So often we just watch and wait. But if it's large and causing significant heart failure, we have to go in and patch it.
Okay, what about an ASD, Atrial Septal Defect? A hole between the atria. How is that different from a VSD?
It's still a left-to-right shunt, so the lungs are still getting extra blood, but the pressure difference between the atria is much lower than between the ventricles.
Ah, okay.
So the murmur is much softer. It's not that loud, harsh sound. It's often described as a systolic ejection murmur with a wide, fixed splitting of the second heart sound.
That sounds very specific.
It's an audiophile's term. But basically, these kids are often asymptomatic for years. They might get diagnosed as a teenager when they get tired playing sports. They're less likely to have that profound heart failure in infancy that you see with a big VST.
So it's a quieter, more subtle version of the same problem.
In a way, yes. Still wet lungs, but less dramatically so in many cases.
Okay, next in this group is the PDA Patent Ductus Arteriosus.
Yeah.
We talked about the drugs. Indomethacin closes it, but what does it sound like?
This is a classic board question. PDA has a machine-like murmur.
A machine?
Yeah, it sounds like a washing machine.
Yep.
A continuous, churning, hum-like sound right under the left clavicle. You'll also feel bounding pulses.
Why bounding? What causes that?
It's because during diastole, when the heart is relaxing, blood is constantly running off from the aorta through the PDA and into the pulmonary artery. This makes the diastolic pressure drop. So there's a wide gap between the top number, the systolic, and the bottom number, the diastolic.
A wide pulse pressure.
Exactly. And that wide pulse pressure makes the pulse feel really strong and snappy, bounding.
Machine murmur, bounding pulses. Give indomethacin to close it.
Got it. Now, what happens if we ignore these defects, if we let the lungs stay wet for years and years?
That's the nightmare scenario. We call it Eisenmenger syndrome.
Eisenmenger.
Eventually, the lungs get sick of being flooded. The delicate blood vessels in the lungs start to harden and thicken to protect themselves. This is called pulmonary hypertension.
And that increases the pressure on the right side of the heart.
Exactly. The right side now has to pump against this super high resistance in the lungs. And if the right side pressure gets high enough, it actually exceeds the left side pressure.
So the shunt.
The shunt reverses. It goes right to left.
Yeah.
The kid turns blue. And once that happens, the damage is permanent and irreversible. You can't just fix the hole anymore. The lungs are shot. That's why we fix these defects early, before that permanent damage sets in.
Okay, that makes sense. Let's move to group B, the obstructive defects, the kinked hose group. Right, so here, the problem isn't a hole, it's a blockage. The king of this group, the one you'll see on exams the most, is coarctation of the aorta.
Coarctation just means narrowing, right?
Exactly. Imagine you have a garden hose and you pinch it in the middle. Pressure builds up behind the pinch and the flow is weak after the pinch.
And in the aorta, the pinch is usually right after the arch, after the arteries branch off to the head and arms.
Exactly. So blood flows easily under high pressure to the head and arms. That's the high pressure zone. But it can't squeeze past that pinch to get to the legs, the gut, the kidneys. That's the low pressure zone.
This leads to the famous 4-extremity blood pressure test.
This is the absolute need to know for coarctation. This is how you find it. If you take a BP in the arm, it's high, maybe 30-30-80 in a child, which is hypertensive.
Okay.
Then you take it in the leg and it's low, maybe 80-50. And the pulses, they're bounding in the neck and arms, but they're weak or even absent in the feet.
Upper body hypertension, lower body hypotension. What does the patient complain of?
If they're older, they might complain of leg pain with exercise claudication because the muscles just aren't getting enough blood flow. And they might get frequent headaches, nosebleeds, or dizziness because of the high pressure in the head.
And the risk here, if it's not fixed?
Stroke from the high pressure upstairs? Or, even worse, rupture of the aorta. It's a mechanical problem that needs a mechanical fix surgery to cut out the narrowed section or a balloon angioplasty to stretch it open. If you see a test question about BP disparity between upper and lower extremities, you click coarctation immediately.
Okay, group C, the scary ones. Decreased pulmonary blood flow, the blue group. This is the right to left shunt.
Yes, and the poster child for this group is tetralogy of Fallot. Tetralogy means 4. You have 4 distinct defects occurring at the same time.
I always use the mnemonic RAPS to remember them. RAPS.
That's a good one.
R for right ventricular hypertrophy, A for aorta overriding, P for pulmonary stenosis, and S for septal defect, a VSD.
That's a great mnemonic. Let's break it down so it makes sense. The real villain here, the one that causes all the other problems, is the pulmonary stenosis. The exit to the lungs is extremely tight and narrow.
So blood can't get out of the right ventricle easily.
It can't. So the right ventricle has to push against this tight door, and the muscle gets huge. That's your right ventricular hypertrophy.
So the blood is stuck in the right ventricle. Where does it go?
It takes the path of least resistance. It looks at the tight pulmonary valve and says no thanks. And then it sees this big VSD, the hole, and it shoots right through it.
To the left side.
And because the aorta is overriding, or sitting right on top of that hole, the blue blood shoots straight from the right ventricle through the VSD and into the aorta and out to the body.
Bypassing the lungs entirely, the result is instant cyanosis.
Right. And this leads to the most dramatic, terrifying event in pediatric cardiology. The TET spell, or hypercyanotic spell.
Okay, paint the picture for me. You're the nurse. You walk into the room. A toddler with known tetralogy of Fallot is crying because they dropped a toy. Or maybe they're straining to poop. Suddenly they turn a deep dark blue. They start gasping. They go limp. What is happening physiologically?
The crying or straining increase their oxygen demand. At the same time, the muscle right below the pulmonary valve, the infundibulum, goes into spasm and clamps down completely.
It slams the door shut.
It slams the door to the lungs completely shut. Zero blood is going to the lungs. It's all shunting right to left and out to the body. They are profoundly hypoxic. This is a medical emergency.
This is a kill zone. What is the #1 priority nursing action? You have seconds.
Knee to chest position. Immediately.
Explain that. Why does shoving their knees up to their chest help? It seems so simple.
It's physics again. When you scrunch the legs up like that, you are kinking the femoral arteries. You are dramatically increasing the resistance in the systemic circulation in the body.
You're making it harder to pump to the body.
Exactly. Remember, blood is lazy. If the pressure in the body suddenly gets really, really high, the blood in the heart says, whoa, it's too hard to go out the aorta now. It forces the blood to try the other path back into the pulmonary artery and to the lungs, even if it's tight.
You essentially force the blood back to the lungs by making the body a harder place to go.
You reverse the shunt temporarily. It's an incredible life-saving maneuver.
So step 1, knee to chest, or if they're older, have them squat.
Yeah.
Step 2, 100% oxygen. Step 3, morphine.
Yes. The oxygen helps with what little blood is getting to the lungs, and morphine is key. It calms the child, which reduces their oxygen demand, but it also has a sedative effect that can help relax that cardiac spasm.
And developmentally, you'll see toddlers doing this on their own, right?
It's amazing to watch. A TET kid will be running on the playground, they'll get tired and short of breath, and they will instinctively drop into a squat for a few seconds.
They're self-treating.
They are. The teacher might yell, "Get up, stop being lazy," but the school nurse should know to say, "Let them squat." They are increasing their systemic vascular resistance and improving their own oxygen saturations.
Incredible. Nature finds a way. Okay, Group D mixed defects. The source material calls this the survival depends on mixing group.
Right. And the big one here, the classic example, is transposition of the great arteries, or TGA.
The plumbing is crossed.
Completely swapped. The pulmonary artery leaves the left ventricle. The aorta leaves the right ventricle.
So, wait, let me trace that. The right side pumps blue blood out the aorta to the body, which comes back blue to the right side and gets pumped to the body again. A closed loop of no oxygen.
Correct. A completely futile deoxygenated loop.
And the left side pumps red, oxygenated blood to the lungs, which comes back red to the left side and goes right back to the lungs again. A closed loop of oxygen that never reaches the brain.
Right. Two separate circuits that never cross.
That sounds completely incompatible with life.
It is, unless there is a connection somewhere. This is where we go back to our fetal shunts. If that baby is lucky enough to have a PDA or a hole in the heart, like an ASD or VSD, the blood can mix and they can stay alive for a few days.
So this is a scenario where you are literally running to the puxes to grab the prostaglandins.
You are not walking. You are starting a prostaglandin drip immediately.
Yeah.
Keep that ductus open. It is the only lifeline, the only bridge between those two circuits, until the surgeons can go in and physically switch the vessels back to where they belong. We call it the arterial switch operation.
And then there's the really tough one, hypoplastic left heart syndrome, or HLHS.
This is one of the most severe and complex defects. The entire left side of the heart, the main pump, is tiny and underdeveloped. It barely exists.
How do you fix half a heart?
You can't fix it in the traditional sense. You have to completely rewire the entire circulation so the single working right ventricle does all the work of pumping to both the lungs and the body.
That sounds incredibly complex.
It is. It takes a series of 3 major staged open heart surgeries over the first few years of life, or the only other option is a heart transplant. These are the most fragile babies in the entire cardiac ICU.
That wraps up the congenital defects, the ones they're born with. Let's shift gears to part 4, acquired heart disease, the afterbirth group. These are kids who were born with healthy hearts but then get sick.
And the scariest one for parents, I think, is often Kawasaki disease.
Kawasaki, it's an acute systemic vasculitis. So inflammation of all the blood vessels. What does this kid look like?
They look miserable. We are talking a high persistent fever, 103, 104, that lasts for more than 5 days. And the scary part for parents is Tylenol or Motrin doesn't touch it. The fever just will not break. They're beside themselves.
So fever for more than 5 days, that doesn't respond to antipyretics. What else?
The diagnostic criteria are very visual. The mnemonic is CRH and burn. C is for conjunctivitis, red eyes, but no goop, no drainage. R is for rash. A is for adenopathy, swollen lymph nodes in the neck. S is for strawberry tongue, a bright red bumpy tongue with red cracked lips. And H is for hands and feet, which get red, swollen, and then start peeling. The burn is the fever.
CRH and burn, that's a good one. And the real danger here isn't the fever itself, it's what the inflammation does to the heart.
Specifically, the coronary arteries. The vessels that feed the heart muscle itself can get inflamed and balloon out, forming coronary artery aneurysms.
If those burst.
Or if a clot forms in them, a 5-year-old can have a massive heart attack.
So the treatment protocol has a huge exam exception.
Yes, this is the one time you will see this. We give aspirin.
Whoa. We are taught in Pediatrics 101. Never give aspirin to children because of the risk of Ray's syndrome, which is liver failure and brain swelling.
This is the one and only major exception. In this case, the risk of the heart clotting off and these aneurysms forming far outweighs the risk of Ray's syndrome. We give high-dose aspirin for its anti-inflammatory and antiplatelet effects.
And what else?
Along with aspirin, the main treatment is IVH intravenous immunoglobulin. It's a blood product that helps to calm the whole immune system down and reduce the inflammation in the arteries.
So if you see a test question asking which child gets aspirin, you look for the kid with the strawberry tongue and the 5-day fever.
Absolutely. And long-term, these kids need echocardiograms for years to make sure those aneurysms don't develop or worsen later in life.
Next up, Rheumatic fever. I feel like this is something out of a Charles Dickens novel, but it's still around.
It is, and it's tragic because it is entirely preventable. Rheumatic fever is a delayed autoimmune reaction to a group A strep infection's strep throat.
So a kid gets strep throat, maybe it's untreated, or maybe they stop the antibiotics too soon because they feel better. Then what happens?
2 to 4 weeks later, the immune system gets confused. The antibodies that it created to fight the strep bacteria start attacking the body's own tissues, specifically the heart valves, the joints, and the brain.
This brings us to the Jones criteria for diagnosis.
Right, the major criteria. One is carditis, inflammation of the heart. Another is polyarthritis, swollen, painful joints that migrate. One day it's the knee, the next day it's the elbow.
And then there's the really strange one, chorea.
Sydenham's chorea. It's involuntary, jerky movements of the face and limbs. It looks terrifying for parents. The kid starts twitching, dropping things, making funny faces. They can't control it.
And erythema marginatum, the rash with red rings on the trunk.
Right. The chorea resolves, the rash fades, but the real permanent damage is from the carditis. It scars the heart valves, especially the mitral valve. That damage is for life.
So the exam tip here is prevention.
It's all about prevention. Treat strep throat. Take all your penicillin for the full 10 days. It's not just about a sore throat. It's about saving the heart valve from being destroyed by your own immune system 20 years down the road.
One more in this category. Infective endocarditis.
This is an infection of the inner lining of the heart. It usually affects kids with existing heart defects, artificial valves, or central lines. Bacteria, usually from the mouth, gets into the blood and sets up camp, colonizing the heart valves.
This leads to a surprising nursing intervention focus.
Dental hygiene. It's huge. The dentist is a high-risk zone for these kids. Every time you clean teeth, you can release bacteria into the blood. So high-risk kids, those with artificial valves or certain unrepaired defects, need prophylactic antibiotics about an hour before any dental procedure.
So good brushing is actually a cardiac intervention for these kids.
It really, really is.
Okay, let's move to part 5. Nursing management and safety kill zones. We've diagnosed the problem, now we have to treat it. And the drugs we use in cardio are not to be messed with. Let's talk about digoxin.
Digoxin or lanoxin. It's an old drug derived from the foxglove plant, but we still use it a lot. It does 2 main things. It increases contractility, which means it makes the heart squeeze harder.
A positive inotrope?
Right. And it decreases the heart rate, a negative chronotrope. It gives the heart more time to fill between beats.
So it makes the pump stronger and more efficient, squeeze harder, beat slower. But the therapeutic window is tiny. The difference between a helping dose and a killing dose is microscopic.
Which is why the need-to-know assessment is the apical pulse. You cannot just feel the wrist. You must put your stethoscope on the apex of the heart and listen for 1 full minute, not 15 seconds times 4. 1 full, uninterrupted minute.
And what are the cutoff rules? When do we hold the drug?
This has to be tattooed on your brain. For an infant, if the apical heart rate is below 90, you hold the drug and you call the provider. For an older child, the cutoff is below 70.
Less than 90 for a baby. Less than 70 for a child. Write that down. Now, how do I know if the kid is toxic? What's the first sign? Just vomiting. Kids vomit all the time. This sounds tricky.
That's why it's so dangerous. But if a cardiac kid on digoxin starts vomiting, especially more than once, or they lose their appetite completely, do not assume it's the flu. Your first thought must be dig toxicity until proven otherwise. Other signs are profound bradycardia, a very slow heart rate, and dysrhythmias.
And there's a critical electrolyte connection here, right?
Potassium. Hypokalemia, or low potassium, potentiates digoxin toxicity. It makes the heart muscle much more sensitive to the drug. So a normal dose of DIG can become a toxic dose if your potassium level is low.
And what's a common drug we give that lowers potassium?
Lasix, furosemide, the diuretic we give to treat the very heart failure we're using the digoxin for.
It's a vicious cycle. We give Lasix to get the fluid off the wet lungs. Lasix makes them pee out potassium. Low potassium then makes the digoxin toxic.
Which is why the nurse has to be a hawk. You are monitoring potassium levels daily. You're encouraging potassium-rich foods like bananas, spinach, potatoes if they're old enough. If your patient is on both DIG and Lasix, you are watching that potassium like your license depends on it, because it does.
Okay, let's talk about the big procedure. Cardiac catheterization. We thread a long, thin catheter up the femoral vein or artery into the heart to measure pressures, fix a valve, or patch a hole. The kid comes back to the floor. What is the #1 kill zone post-procedure?
Hemorrhage. We just poked a hole in a major artery or vein in the groin. If that clot blows, the kid can bleed out into their thigh very, very quickly.
So how do we assess for that?
You check the dressing, obviously, for any visible bleeding, but blood follows gravity. If the kid is lying on their back, the blood might not come out the front. It might pool under their leg and buttocks, so you have to physically slide your hand under them. If you feel wetness, check your glove. Is it blood?
And you have to check the pulses below the site.
Absolutely. Check the pedal pulses in the foot on the affected side. If that leg is cool, pale, and the pulse is weak or gone, you may have thrown a clot that's blocking the femoral artery. That is a medical emergency. The leg could die.
What's the main nursing intervention to prevent bleeding?
Keep the affected leg completely straight. No bending at the hip. For 4 to 8 hours, depending on the protocol.
Have you ever tried to keep a 2-year-old's leg straight for 6 hours?
It is a special kind of nursing nightmare. This is where pediatric nursing becomes an art form. You use soft knee immobilizers, you use iPads, you read books, you have parents literally hold the leg. But they cannot sit up because sitting up flexes the hip, puts pressure on that groin site, and can pop the clot.
And if you see active bleeding, if the dressing suddenly becomes soaked with blood.
Direct, firm pressure, but not just on the little Band-Aid. You apply pressure with your gloved hand about 1 inch above the insertion site. You're trying to compress the artery proximally to stop the flow coming from the heart. And you hold it and you yell for help. You do not leave that room.
Okay. We've covered the drugs, the procedures. Let's touch on the day-to-day management of congestive heart failure, or CHF. The goal is to decrease the workload on the heart. How do we feed these babies?
Right. We mentioned the sweating. Feeding is work. It's a marathon for them, so we need to make it as easy as possible.
How do we do that?
A few key ways. 1. Small, frequent feeds. Don't overfill their stomach because a full stomach pushes up on the diaphragm and makes it even harder to breathe. Every 3 hours is standard.
Yep.
2. High-calorie formula. Standard formula is 20 kilocalories per ounce. We might fortify it with extra powder to make it 24 or even 30 kilocal per ounce. The goal is more energy and less volume.
And what about the mechanics of eating?
3. Use a soft nipple with a slightly larger hole. We don't want them working hard to suck.
Yeah.
The milk should almost drip into their mouth with minimal effort.
And if they take longer than, say, 20 or 30 minutes to finish a bottle?
You stop. If they are still trying to eat after 30 minutes, they are burning more calories than they are taking in. It's a net loss. At that point, you have to prioritize growth over the skill of eating. You drop an NG tube and you gavage feed the rest of the formula. It's about conserving every last calorie.
And what about positioning?
Keep them in a semi-Fowler's position, even in the car seat. Keep their head up. It allows for maximal chest expansion and makes the work of breathing a little bit easier.
Part 6. Psychosocial and family. We can't forget the parents.
Yeah.
They are terrified.
They are grieving. They expected a perfect, healthy baby, and now they're in the ICU surrounded by tubes and wires and beeping machines. They often feel intense guilt, like they did something wrong, and they live with the constant fear that the child will die.
So what's our role?
Our role is to be a calm, clear educator. You need to explain things simply. Get a whiteboard. Draw pictures of the heart. Here is the hole. Here's the patch the surgeon will put in. Empower them with knowledge. Let them participate in care bathing, changing diapers, to restore some sense of normalcy and control.
And what about activity restrictions for older kids? The kid with a big scar on their chest who wants to go play soccer. What do we tell them?
For most repaired defects, we generally tell them to self-limit. The child knows their body better than anyone. If they get tired, they will stop and rest. We don't usually have to bench them from sports unless it's a specific arrhythmia condition or they're on anticoagulants.
But there's a very specific safety rule for kids who have had recent open heart surgery, the sternotomy care.
Yes, this is a big one. After open heart surgery, their sternum is wired shut. It takes about 6 to 8 weeks to heal. You absolutely cannot lift that child up under the arms.
Why not?
If you pick them up by the armpits, you can pull on that healing bone, pop the wires, and destabilize their entire chest. It's incredibly painful and dangerous.
So you have to teach parents to scoop the butt, not pull the arms. Good tip. Okay, we have covered a massive amount of ground, from pressure gradients to strawberry tongues to keeping legs straight. Let's wrap this up with our big 3 takeaways. If our listener is walking into an exam tomorrow, what are the 3 things they absolutely must have locked in?
Okay, number 1, hemodynamics is king. Don't just memorize defects, understand the flow. Left to right is wet and pink, right to left is blue and cyanotic. If you know the pressure, you know the symptoms.
Okay, number 2.
Number 2, safety first. Know the digoxin hold parameters, less than 90 for infants, and always watch the potassium. And know the tech spell drill, knee chest position immediately. Those are life or death concepts that will be on the test.
And number 3.
Number 3, assessment nuance. A sweating baby is a failing heart. A crying infant gives you bad data, so get your vitals when they're quiet. Trust your eyes and your hands, not just the monitor.
Brilliant. And as we close, I want to leave our listeners with a provocative thought. We spend so much time and energy fixing the pump, the plumbing, the valves, the pressure. But what about the computer that the pump serves?
That is the new frontier of research in this field right now. We are saving these kids' hearts with amazing surgeries. Mortality is way down. But we are now finding that children with significant congenital heart disease have much higher rates of neurodevelopmental delays, ADHD, and learning disabilities later in life.
Is it the time on the heart-lung bypass machine during surgery? The periods of low oxygen before they get fixed?
It's likely a mix of all of the above. The brain is incredibly sensitive to perfusion and oxygenation, especially in those first few years. So as nurses, our job doesn't end when the incision heals. We need to be screening these kids for developmental delays. We need to be pushing for early intervention. We fix the hardware, now we have to protect the software.
We fix the hardware, now we have to protect the software. That is a powerful place to end. To all the nursing students and nurses out there tackling this unit, you can do this. Blood is lazy. Follow the flow. You've got this.
We've got this.
Thanks for diving deep with us. See you next time.